Just I want to say something else regarding the evaluation form that we have prepared for this course. So we will share the links in the chat box, and I kindly request all the participants to fill in that form, because it will help us to know what has been the strengths and weaknesses of our course, and it will help us to design maybe better courses in the future. So just please fill in, and it doesn't have any effect on, I mean, the content. I mean, the answers you will enter in the questionnaire will not affect the certificate that you will receive. Just fill it to receive your certificate. So without any effect, your answers we will consider them anonymously. So just please fill in the form to let us know how our course has been, and it will help us a lot. So we will share the links, and you can, it is in the Google Docs, and you can fill in the questionnaire. And in two parts of it, just because there is a Likert scale, a 5-point Likert scale for the answers. So in that two parts, you should just scroll to the right to see all the answers. And then, because if you are here with your phone, you may just see 3 of the 5-point scale. So you should go just to the right, scroll to the right to see all the answers and choose the option that you want. Okay, so thank you very much. Dr. Mutawassilian, please go ahead.
Thank you, Professor Khami, for the explanation you had. And now the time for lecture, Professor Shamshiri. It would be appreciated if Professor Shamshiri kindly present his lecture for the audience. Stage is yours, please. Professor
Hello, everybody. Thank you very much. I'm trying to share my screen. Just a moment, please. Okay. So can you see my screen?
Yes.
Good. So thank you for presentation of Dr. Nekufar. Accidentally, I want to emphasize on part, the first part of his lecture, and I want to emphasize in my presentation on the role of experts or expertise in evidence-based dentistry. My topic is about interpretation of evidences. We are here in steps of evidence-based practice after forming answerable question, after searching for evidence and appraising the evidence. We are here to make decision, to make a clinical decision for our patient and to apply. And as Dr. Nekufar mentioned, we should check our practice and find gaps of effectiveness and, for example, failures, and we should revise our practice. Okay. In this session, I will try to show the level of strength of evidences, and for example, in a clinical guideline, when you look at the recommendation, you should know the strength of the recommendation and the role of evidence in clinical decision making. Unfortunately, for applying the evidences in the practice, it's not clearly mentioned in the evidence-based practice the documents. For example, as mentioned here, evidence-based medicine or dentistry does not offer any systematic approach to the interpretation of the knowledge sources. So I want again emphasize on the definition of evidence-based practice, which is integration of the best available research evidence with clinical expertise and patient values, these circles. And for example, the specific definition for evidence-based dentistry by ADA, an approach to oral health care that requires the judicious integration of systematic assessments of clinically relevant scientific evidence, obviously related to patients' oral and medical condition and history, with the dentist's clinical expertise and patient's treatment needs and preferences to get the best result for the patient. These definitions of evidence-based practice, although the emphasis is on best evidence, but the best evidence does not replace clinical skills and judgments and experience of the practitioner. So I want to emphasize again on the expertise in this step of evidence-based practice again. If the evidences is strong for your clinical question, the importance of the evidence on your final decision making is high. However, if the evidences are weak, so your decision is mostly based on your expertise and the patient's value. Look at level of evidence again. As Dr. Nekufar mentioned today, according to the Oxford Center of Evidence-Based Medicine, the best level of evidence is for systematic reviews and meta-analysis of randomized controlled trials as 1A, and individual randomized controlled trials as 1B. Then it's pertaining to cohort studies, next case control studies and cross-sectional studies, then case series, and the fifth level is for expert opinion when we have no other evidences available. However, it's not always applicable for all type of questions. As you know, we have different clinical questions related to therapy, related to diagnoses, etiology and causation, or for harms and side effects, and for prognosis. For two of these four types of questions, the best level of evidence is pertinent to randomized control trials and systematic reviews of randomized control trials. I mean for therapy and prevention, and for etiology and causation and side effects. For diagnostic questions, the best evidences is related to those studies with follow-up. So I mean cohort studies and systematic reviews of these type cohort studies. And also for prognosis, we can't perform randomized controlled trials. So the best evidences is related to inception cohort studies. And again, Systematic reviews and meta-analysis of inception cohort studies are above single cohort study. And here, for those who do not know the inception cohort studies means those studies that enter the patients from time of start of disease, from the time of diagnosis. So, because when you get the patient from the middle of the disease, for example, the diagnosis done in previous year, and you find the patient in this year, it's not an inception cohort. You should follow the patient from the time of a start of disease or diagnosis. So according to the type of questions, we should find the best evidences. And as I mentioned again, for therapy and prevention and etiology and causation and harm, the best is systematic reviews of RCTs, and for diagnostic studies and prognostic studies, the best is cohort studies, because we have no randomized control trial for these type of questions. For first example, I want to see you evidence-based clinical practice guideline on antibiotic use for the urgent management of pulpal and periapical related dental pain and intraoral swelling, a report from American Dental Association. Here is the first page, and you can see the different colors. I want to see you one by one. Here is grade certainty of evidence. A grade is a checklist with some criteria to evaluate clinical guidelines. So the grade here is the name of the checklist for validation of clinical guidelines. For certainty of the evidence, the high is pertinent to we are very confident that the true effect lies close to that of the estimate of the effect. So the recommendation for your PICO, if is highlighted by high certainty according to the grade, it means that the effect lies close to that of the estimate of the effect. The next one is moderate. We are moderately confident in the effect estimate. The true effect is likely to be close to the estimate of the effect. And if the recommendation is highlighted by low, it means that our confidence, it means other recommendation, their confidence is the effect estimate is limited. And for very low, it means we have very little confidence in the effect estimate. Next table. Okay. From the left, you can see the recommendations provided by the guideline is divided for application to the patients, to the clinicians, or to the policymakers. So there is not a single recommendation for different target population. We named them these type of population stakeholders, patients, clinicians, and policymakers. And the recommendations categorized as strong recommendations and conditional recommendations. For example, for patients, you can see the strong recommendations. Most individuals in this situation here, most individuals in this situation would want the recommended course of action, and only a small proportion would not. And the strong recommendation for clinicians means most individuals should receive the intervention. And for policymakers, strong recommendations means the recommendation can be adapted as policy in most situations. However, for conditional recommendations, here for patients, it means the majority of individuals in this situation would want the suggested course of action, but many would not. So it depends on the patient. The conditional recommendations for clinicians is the second row. It means recognize that different choices will be appropriate for individual patients, and that you must help each patient arrive at a management decision consistent with his or her values and preferences. And for policymakers, conditional recommendation means it will require substantial debate and involvement of various stakeholders. So by these categories and these remarks, they try to guide the users of the clinical guideline to make the appropriate decision. And here is the recommendation, for example. So here, as you see at the top, expert panel recommendations and good practices statements. So here you see that the certainty of the evidence is very low because it's based on the expert opinion. And here, the expert panel suggests dentists do not prescribe oral systemic antibiotics as an adjunct to definitive conservative dental treatment for immunocompetent adults with symptomatic irreversible pulpitis with or without symptomatic apical periodontitis. As you see, the certainty is very low and the strength of recommendation is conditional. It means when you want to make a clinical decision for this question, you should decide mostly based on the patient's values and your expertise. For next question, the expert panel again recommends dentists do not prescribe oral systemic antibiotics as an adjunct to definitive conservative dental treatment for immunocompetent adults with pulp necrosis and symptomatic apical periodontitis or localized acute apical abscess. Again, the certainty is very low. However, the strength of recommendation is strong. It means that in most cases, it should be done. Another example, a non-surgical treatment of chronic periodontitis by scaling and root planning with or without adjuncts, a clinical practice guideline. Apart from the details, here you can see there are a different classification for saying that the strength of the recommendations is strong or in favor, means moderate or weak, or here based on expert opinion in favor of recommending the intervention or against the intervention, and other classifications. For example, here is a question: scaling and route planning, no adjunct for patients with chronic periodontitis. Clinicians should consider scaling and route planning as the initial treatment. Here, the strength is in favor. It's not strong, but it's moderately recommended. And so on for other PICOs. Okay. Applying the results of the evidence in clinical practice. Once the methods are determined to be valid in a step for critical appraisal, the fourth step is to determine if the results, potential benefits or harms are important or not. So here we should focus on the association between each intervention and the related outcome. The strength of the association, here I want to emphasize that the strength of association is related to clinical importance, not a statistical significance. We should at first define the clinically important difference between intervention and its comparison, and then should look at the p-value, for example. And at the last but not least, the condition of interest. It means the patient's problem, the circumstances and context, for example. Here, statistically, you can find the difference between intervention group and control group or comparison group in different ways. When the outcome is a continuous variable or quantitative variable, they provide, for example, mean differences, or they provide the change of the outcome in comparison to their baseline as a percentage. For example, a 50% increase or decrease of a continuous variable, and they report mean changes in percentage. Or if the outcome is a categorical variable or qualitative variable, they provide odds ratios, for example, to say the association between the intervention or risk factor with the side effects or disease, or risk differences, a different type of risk differences, risk reduction, absolute risk reduction. Sometimes they said attributable risk, and or they interpret the strength of association with some indices like number needed to treat, the number of patients you should treat with new intervention to get one benefit more than routine care. NNT means the number of patients you should treat with new intervention to get one benefit more than the routine care. Or other indices, for example, number needed to harm, and so on. Now, a question. Which intervention is better? Those interventions with high NNT or those interventions with low NNT? Dr. Motawassilian, I can't see the Zoom screen. Please.
Yes, I'm here.
Yeah, please tell me the feedbacks of participants. Thank you.
I should answer or the participant?
They should send one if they think the high NNT is better than the low NNT, or send two if they think low NNT is better than high NNT.
I think high intent better.
So what's the feedback of
five,
the participants?
Yes, we have now 5 twos.
Okay, okay.
And no one.
Good, excellent. Because the number of, if you get more benefits with a smaller number of patients, so the intervention is highly effective. It's good. Thank you. Thank you for all participants. Good. So the right answer is low NNT. Thank you. Again, if you want to interpret the evidence based on a statistical, you should first focus on the strength of the association of intervention and outcomes, because the clinical importance is more valuable in your practice than a statistical significance. So at first check for clinical importance and then check for the p-values. And with the statistical nomenclature, it refers to effect size. The effect size is somehow complicated from clinical importance, but it contains clinical importance, and also it emphasizes on the precision of the statistical inferences. I mean 95% confidence interval. So high association with low precision is not good. They resulted from those studies with low sample size. But if you get a high strength with a study with high sample size, so the precision is high and the effect size is very high, and you can rely on the both clinical importance and statistical significance. Now, beside of a statistical aspect for interpreting the evidence, here I want to focus on expertise and the role of expertise in interpretation of evidence, because there are some problems when you want to rely on the evidences. You have a good PICO question, you find some evidences related to your question, and you appraise them, and you find that those sources of information are performed perfectly, they reported carefully, and you can rely on their results. However, hypotheses are based on contextual knowledge. Trial designs is influenced by personal preferences, and interpretation of trials in their conclusions results depends on prior beliefs. So, for example, if you practice in Iran, the evidences from the Europe may be completely different from your contextual area. The researcher preferences and beliefs to conclude from their researches completely may be different from your country and your expertise and your patient values. So here you should rely more on those evidences that are closer to your contextual knowledge and your patient's values. Is somehow related to the philosophy of science. There are arguments between new interventions and routine practice, and there are two main approaches to decide which one is better, deductive approaches or inductive approaches. And all of them have sound and unsound decisions, or strong or weak decisions. So we should perform more practice. We should try harder to find the best evidence for decision making. Relying on the recommendations of perfect guidelines, it may be not work for your patient. And this is a hard step here. Excuse me. Okay. So, expert opinion plays an important role in all essential steps of the pursuit of knowledge in the research tradition. Here, they want to say that expertise and expert opinion is a complementary rather than the hierarchy ranks. So it's better to pay more attention and to get more roles for expertise and your expert opinion when you want to decide which recommendation is more beneficial for your patient or which one not. My presentation is finished sooner than the schedule, and here is my references. If there is any question, I'm here to answer you.
Thank you, Professor Shamshiri, for your presentation, and very nice view you have at the end from the snow on the mountain. It's great.
It's your kindness. Thank you very much.
Your presentation, your great presentation, was ended with a very beautiful picture on a mountain with the snow cover all the surface. Thank you, I appreciate it. I enjoyed it. I need, if I were, I do not know, if I were the other student and other participant, I review the slide that Professor Shamshiri presented to us, to review all this information, to use all of them practically in our practice and research, to know how we can evaluate and judge them, judge the evidence that we have, judge how to interpret the data that we had. We need to evaluate again and memorize them to practically use it. Professor Khami, do you have any recommendation?
Okay, so thank you, Dr. Shamshiri, for your presentation. So as the final step of evidence-based approach, you covered nicely the area of integration of the evidences. And now we have time for some questions. I think if there's any comment or question by the audience, we can now have the questions, and then just a small break. And then at the last presentation and conclusion of the whole course, I will have some slides to present. Okay, so if there's any question or comment by the audience, we can now have the comments and questions. I just again request all the participants to fill in the evaluation form. The link is in the chat box, so you can easily follow the link and complete the questionnaire. It has some different parts, and at the end of the question, at the end of the form, we have a place for your comments and suggestions. please write down if you have any regarding the whole course or any specific topics in the course. So it will be the benefit of the future courses if you want to have.
Thank you, Professor Khami. Apparently, there is no question.
Yes.
Before starting the next part, is there any? No, there is no question. So do we have 10 or 15 minutes break?
Yes, I think 15 minutes is okay. And then we'll
so
continue.
in 15 minutes, we ask all the participants come back and again join us to continue. And we have a presentation. We would have a presentation by Professor Khami and a short question and answer. Okay, I will come back and you come back again in 15 minutes. Thank you.
Thank you.
Thank you.